All right. Hi, I'm Miriam Peckham. I'm one of the spine radiologists here at the U. So we're going to be doing an introduction to spine, which is everybody's favorite topic, I'm sure. All right. So the goals of this lecture, the majority of you are not going to be going into radiology. You'll probably go into a primary care surgical specialty. So I think most importantly, it is good for you to have an idea of what kind of imaging you want to order to answer your questions. Second thing I want to talk about is just basic anatomy of the spine. And then the third, I want to give you an introduction to trauma, degeneration, and then infection and malignancy. Okay, so what study am I supposed to choose? I want you to use imaging to your advantage and have an idea of which study is best to answer your question. So I put this in here. I know that most of you won't be just jumping to order MRI, but you'd be surprised at how many people think that MRI is fancier, therefore better. So they'll say, oh, I want an MRI when they really should be ordering a CT. So we're going to talk about when you should be ordering an MRI versus a CT, but hint, MRI is not the best study to answer all of your questions. Okay, so we're going to look at radiographs versus CT versus MRI, when you should order each of them. So the big thing here is if you want to look closely at the bones, the CT is the best study for you to order. It is the most sensitive study for detecting fractures. All right. All right, so this is just an example. Here you have an MR, obviously, and then here you have a CT. And if you're looking for fractures, you can see them actually quite well on the CT. And here on the MRI, you know, you'd be hard pressed to tell me exactly where the fracture deformities are. All right, so when do we use MRI? We're going to use MRI to look at soft tissues, the central nervous system structures. That is what MRI is best for. So you can see here, not only do you have your fracture deformity, but you also can look at the cord, which has some increased signal in it. And then you can look at the soft tissue injury. So this is a 3-column injury that you can see really well by MRI. Here's another example. On the CT, you're really not seeing anything all that impressive. This is a post-traumatic cervical study. But here you can see there's actually some intradiscal signals showing that there is some injury, and then you have soft tissue injury along the back here. This is another example. You have a compression deformity here, or burst fracture is what we would call this. And here you can see all of the hemorrhage within the region of the disc. You can see the retropulsion of the bone. And then here you can see the squished spinal cord, now soon to become the conus. It's terminating here. And even more importantly, you can see this epidural hematoma. So you can see how MRI is showing you quite a bit of a more complete story than CT would. But again, you're going to need CT first off to look for all of those more subtle acute fractures. All right, MRI is also really good for non-displaced fractures as well as malignancy. So we'll talk about this a little bit later, but the normal T1 fat signal in the spine is bright, and you can see all these dark things in the middle of what should be bright. And this is actually an example of multiple myeloma, showing you how malignancy can show up well on an MRI. Here's another example. You can see this fracture right here on the CT, and then the other vertebral bodies you wouldn't think much of. But when you look up on the MRI, you can tell that there's actually edematous signal within this vertebral body. So you can note that there's actually been a contusion of the bone here. So it's a non-displaced fracture. There's not much height loss, but you can tell that this person has had an injury to this vertebral body as well as this one. So again, MRI is very sensitive for edema, and it's helpful in cases like that. All right, so when do we use radiographs? Well, radiographs are very, very good for dynamic motion. And the reason they're good is because the patient is weight bearing. They're standing up during the radiograph. So this is just a small example here of one vertebral body on the other, and it's actually shifting position. And this is an example of what's called dynamic listhesis, which tells us that there is something wrong with the facet joints. So on MRI, you're only going to get a static view. This person is lying on their back, and you can see small little effusions within the facet joints. But again, that doesn't tell you much. Once you stand the patient up and have them move around, the radiographs are incredibly helpful because now you're realizing, oh, this patient is actually having motion at this level, and you can see the motion on the radiograph. All right, what about low suspicion screening? So in the past, a lot of people have used radiographs for low suspicion trauma screening, and that is not incorrect. If you really don't believe the person has injured themselves seriously, but it's something that you want to take a look at and not necessarily go the distance of a CT, you can do it. So what does the ACR say about this? They say that a patient suspected of having the injury can get a radiograph if multi-detector CT is not readily available. So you can use it if you're not able to, if you don't have access to a CT. But again, CT is much more sensitive for finding fractures than radiographs. All right, and then vasculature, you would use either a CTA or an MRA. In the setting of trauma, if you want to get two birds with one stone and you want to look for fractures as well as vascular injury, you're going to order a CTA, and this is just an example of a patient that has a facet injury here, and you can see that the vessels are okay. Okay, what about IV contrast? A lot of people wonder, when am I supposed to use it? When am I not supposed to use it? And sometimes the radiologist will change your order and you're not sure why. So IV contrast is indicated in a workup for infection, inflammation, or malignancy. Initial trauma workup, you're not going to need IV contrast. If you're looking specifically for vascular injury, that's usually a follow-up study. It's not always ordered first off. You're not, theoretically, in your initial CT for trauma workup, you're not going to be using contrast. What about a CT myelogram? A lot of people ask about CT myelogram. For those of you that don't know what a CT myelogram is, it's when we put a needle in the spinal canal and we inject contrast to make the spinal canal light up. So the only time we would use this is in a patient that cannot have an MRI, because an MRI is generally always going to be better than a CT myelogram. Otherwise, we use it in very specialized studies to look for CSF leak and arachnoid adhesions, and all of that is kind of beyond the scope of this lecture. But again, a CT myelogram is never going to be a first-off study for just about anything. Okay, so just to simplify what I just said, patient comes in, they have pain, and they've met all the clinical criteria to get an imaging study. The simplest algorithm for you to remember is, did they have trauma? If they had trauma, get a CT, because you don't want to miss any subtle fractures. If it was completely atraumatic and they're just developing low back pain and they meet the clinical criteria, and by that I mean usually greater than 6 weeks of chronic pain that does not respond to conservative therapy, blah, 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 blah. In that case, you're going to get an MRI, because you're not thinking as much about fracture, you're thinking more about degeneration and a few other things that may be causing pain. So again, trauma, think CT. No trauma, and they meet clinical criteria, think about MRI. These are just a bunch of different situations. So acute trauma, CT. Is the CT normal, but they still have tenderness to palpation? Then again, you can think about those non-displaced fractures that we saw an example of earlier. You can get an MRI. If they have nerve pain that's shooting down their leg, you're going to think about getting an MRI again. So anything atraumatic, question for infection, atraumatic, question of cancer, those sorts of things you want an MRI. Anything traumatic, you're going to want to think about a CT. And then if you're going to be looking at fracture stability, again, you want an exam that's going to look at motion. So radiographs are going to be your go-to exam because, again, you want to look at motion. Any question on spine imaging? We have many, many sources online, but the main one is this ACR appropriateness criteria. It can answer all of your questions. When should I get this? When should I get that? And is pretty invaluable, especially early on when you're trying to figure out what imaging study to get. Okay, question number 1. We have a 16-year-old, history of a motor vehicle collision. They have tenderness to palpation in the mid-spine. Which study are you going to order first? Are you going to get an MRI with and without contrast? Are you going to get a CT without contrast? Are you going to get a CT with and without contrast? Or are you going to get a radiograph? All right, hopefully you have figured out the answer to that based on the first part of this lecture. All right, let's keep going. So now we're going to talk about anatomy. I know that many of you had your last anatomy course probably a couple of years ago, so I'll go through this. I'm not going to go in a ton of detail, but just enough to have you recognize what it is we're looking for on some of these exams. So cervical anatomy, obviously, it's a lot more complicated when you're looking from the occipital condyles to C2. It's a very, very different anatomy than the rest of the spine. We have all of these different ligaments that are helping, keep things in place. The ones that we specifically look for quite a bit in studies are the alar ligament, and then we look at the transverse ligament, which you have here. All right, so the alar ligament, I don't know, hopefully you can see this well, it's kind of a blurry image. But the alar ligament is going from the tip of the dens up to the occipital condyles. All right, so tip of the dens to the occipital condyles. The dens is actually part of C2, right? So it's going from C2 to the occipital condyles. The transverse ligament runs behind the dens. I like to think about this ligament as a seatbelt ligament. So when the dens is trying to move, let's say there's some sort of traumatic event happening, the transverse ligament is there to keep it in place from moving too far back. All right, so those are two very important structural ligaments. All right, this is just on a sagittal view. It just shows you how much detail we can see these ligaments on an MRI. Remember, we're looking at soft tissues here. That's why we would use an MRI for this sort of study. So these are all of the different ligaments that I was telling you about. The cruciform ligament is actually the transverse section is part of the cruciform ligament. So that's all, one type of ligament. That's why the name looks different. The apical ligament right here, again, tip of the dens, you see that, going up to the occiput. And then, I'm sorry, that's the alar ligament. Apical we're seeing very well in the sagittal. Sorry, mixed up my A's. You can't see the alar ligament well here at all. And then we have the anterior atlanto-occipital membrane. Okay, so again, the two I wanted you to focus on, the alar ligament going from the tip of the dens to the occipital condyles. It's diagonal, again, running from these two locations. And then the transverse ligament, again, the seat belt of the dens. The transverse ligament is part of the cruciform ligamentous complex, but again, it's the transverse portion, and it acts like a seat belt for the dens not to fly backwards. And then alar, again, tip of the dens to the occipital condyle. All right, seeing as I literally just gave the answer to this question, I hope you all get it right. The alar ligament extends from the A, dens to the occipital condyle, B, dens to the C1 lateral body, C, base of C2 to the C1 lateral body, or D, C1 lateral body to the occipital condyle.
Dr. Peckham, can I ask a question about something you said in the lecture?
I mean, A is in grade, not A is in answer. Okay, anyway, let's go on. So we talked about the atlanto-axial complex and the different anatomy there. Now we're going to talk about subaxial. When people say subaxial, it essentially just means the rest of the spine below the atlanto-axial complex, because again, the atlanto-axial complex is so different, it really has to be talked about separately. So this is the subaxial cervical anatomy. So this is just taken straight from Netter's. If you remember all of the different parts of the vertebral body, and we'll talk about it later. So here's the vertebral body. Here are the posterolateral elements, right, where the facets live. This is the spinous process. And again, this is just the spinal cord in the center, and then the nerves coming off of the spinal cord going through the neural foramina. And you can see that the neural foramina in the cervical spine runs very, very closely to the transverse foramen. And what lives in the transverse foramen? The vertebral artery. Okay, so I'm going to break it down for you further. The cervical spine has 5 joints. It has an intervertebral joint. I know we don't always think about this as a joint, but it is. It is connecting 2 bones, therefore it is a joint. Then we have 2 facet joints. And then a joint that a lot of people don't think about, we have 2 uncinate or uncovertebral joints. Uncinate and uncovertebral mean the exact same thing. You just choose to use one depending on who you trained with and what they like to use. All right. That was pretty much the anatomy of the cervical spine that I want to highlight. So now we're going to talk about trauma. We've talked about anatomy of the atlanto-axial complex. We've talked about the anatomy of the cervical vertebra. We've talked about the joints in the cervical vertebra. So now we're going to talk about how we look for things. So number 1, you want to look at alignment. You want to look at alignment in the atlanto-axial complex, and then you want to look at alignment in the subaxial spine. So the remainder of the spine that is all somewhat the same. You also want to look at the vertebral body heights and the width. You want to look at the disc space height. You want to look at the interspinous distance. And then finally, you want to look for fractures. Okay, so the atlanto-axial complex. This is what it should normally look like. This is where the apical ligament lives. This is the dens, right? So that transverse ligament is behind it. Here we have the joints. This is the occipital condyle to C1, and this is C1 to C2. Occipital condyle to C1 is like a ball and socket joint. C1 to C2 is flat. Why is it flat? Because you want to be able to shake your head no, and that's what allows you to do it, is this flat joint. All right, so what are the things we look at? We look at things like the basion to dens interval. The basion is just the bottom of the clivus. So this is just the distance between the dens and the base of the skull. Why do we look at that? Well, this is a child that presented after a very, very high rate of speed motor vehicle collision. Look at this. There's this huge distance from the tip of the dens to the skull base. Very, very, very large distance. This essentially is a decapitation. So this patient has been, oh, I can't hear you guys. I wish I could, but I can't figure out how to hear you guys through this thing. Sorry, I just looked at the chat and saw your questions. Okay, but you can see there's this really, really large space between the skull base and the dens. So this patient essentially has gotten decapitated. If you guys have any questions, please just go ahead and type it in the chat, because I'm not sure if I'm going to be able to hear you guys through this. All right. Then you look at the atlantodental interval. What is that? Well, this is the atlas, otherwise known as C1. This is the dens, and you look right here. Remember, what are the ligaments that live here? You've got the transverse ligament going by here. You also have the alar ligament going this way, right? So you want to make sure that all of the spaces are symmetric. This is just an example of an asymmetric widening. So here you're concerned that there has been ligamentous injury causing this space to widen between the dens and the atlas, or the lateral body of C1. Then you have the atlanto-occipital articulations. This is between the occipital condyle and C1. And here you can see it's widened. And then you also want to look at C1 and C2. And again, here, this one actually looks pretty good. So here I would say this is widened. This one, not too bad, though probably slightly widened. All right, and then finally you want to look at the dens itself. So the dens itself can be fractured. There are 3 different types of dens fractures, and we won't go into all of that. Sure, so a scenario in which I would order a CT scan with is if the patient is getting a full body scan, if they're essentially getting pan scanned and you're looking at chest and abdomen and pelvis, and you're already giving the patient contrast for those areas, and you want to scan the spine at the same time, then often we will have contrast on board when we read those. But again, if you're only doing the spine, specifically only the spine, and you're looking for fractures, contrast is not necessarily necessary to make fractures show up any better. If you're wanting to do what's called a CTA, and you're wanting to look at vessels and fractures simultaneously, some people will do that, but the majority of the time the CTA will be ordered after we have already found a fracture, and specifically a fracture that is high risk for a vascular injury. Most people will not be ordering that study right off of the bat. Good question. All right, so now we're going to talk about alignment. You guys probably remember a lot of these lines, but here are the names. This is the anterior marginal line along the front of the vertebral body, the posterior marginal line, the spinolaminar line, which is where the lamina connects to the spinous process, and then the posterior spinous line, which goes along the spinous processes. All right, the other thing we like to look at is the distance of the facets. So here you can see all the facets are well lined up with each other. This is an example where that is not so. So if you look at this image, you can see the facets are lined up, but look at this facet. It literally jumped from being right here forward and is now locked on top of the facet below it. What does that do? Well, you can tell it does an extensive amount of damage. So look at this. This vertebral body has a large amount of traumatic listhesis over this vertebral body, which means the poor spinal cord in here is getting completely squished. And this is the patient that suffered paralysis after this trauma. Again, you have a facet that actually jumped the facet below it and is now stuck on this facet, and it's caused the whole spine above this area to be pushed forward. This is called traumatic listhesis, and I will just give you a hint. I will be asking a question about this later. So if you have a large amount of traumatic listhesis, you want to think about the alignment of the facets, because oftentimes the facets are what is causing such a huge amount of offset. All right, so you also want to look at the vertebral body heights. We've seen multiple examples now of fractures that smush the vertebral bodies. So that is something you want to pay special attention to. And then you want to look at the vertebral body AP distance. This is just an example. You can see this vertebral body is a little longer than the others, and that's because it has a flexion teardrop fracture that's offset from it. And then finally, you want to look at the distances of the disc spaces. Interspinous distances. How do these help? Well, sometimes this patient, you obviously can see they have a fracture through the pedicle of C2. But if you didn't know that, if you're only looking at a sagittal view, you could see, wow, there's a big amount of distance between C1 and C2 that's not normal. And that would cause you to go and start looking very, very closely for fractures. So just looking at the alignment of the spinolaminar line, as well as the line that goes along the spinous processes, gives you an idea if you're missing some injury. And then finally, you want to look at the soft tissues, because those give you clues as well. All right, question number 3, and I kind of hinted at this already. If you have a large degree of traumatic listhesis, so abnormal alignment of a vertebral body on another vertebral body, this is going to be suspicious for primary displacement of which joint or joints? Is it A, the intervertebral joint? Is it B, the facet joints? Is it C, uncovertebral? Or is it D, atlantoaxial? All right, so big offset of one vertebral body on another. You want to make sure to look at which joints to figure out why that happened. Okay, now we've talked about cervical anatomy. We talked about the atlanto-axial complex. We talked about the subaxial cervical spine. Now let's talk about thoracolumbar anatomy. So thoracolumbar anatomy is a bit different than cervical. The neural foramina are a lot more, I guess, side-to-side transverse than cervical. Remember, cervical, your nerve was coming out a little more anteriorly. In this one, the nerves are coming out more side to side. And that way you can see the foramina really, really well just on a lateral or a sagittal view. We have the vertebral body. You have your transverse processes, you have your spinous process, but what joint is missing? We have the facet joints. Well, the big difference between thoracolumbar and cervical is the absence of one of the joints. So in the thoracolumbar spine, we do not have the uncovertebral joint. That is something very specific to the cervical spine. The thoracolumbar spine, you do not have it. All right, so that's why we go from 5 joints down to 3 joints. Thoracolumbar spine, you have the intervertebral joint, so right here, the 2 vertebral bodies stacked on each other with a disc in the middle. And then you have the 2 facet joints, and they're highlighted here. All right, so you have your facets, and then you have your intervertebral joint. Again, you do not have an uncovertebral joint like you do in the cervical spine. All right, so what about the spinal cord? We know the spinal cord is running all the way down, essentially from the medulla, all the way down into your butt. But the cord itself ends at L1-2. So after the cord ends, which I guess is not, it's more your mid-back area, not mid-back, lower to mid-back, either way. The cord is going to end at around L1-2, and then it's just going to turn into what are called the cauda equina nerve fibers. All right, so your cord is going to end up around this level, and then on an axial, you're going to see it turn into all of these little nerve fibers, and it's called cauda equina because it's meant to sound like, I think it's a horse's tail is the meaning of that. All right. So alignment, again, is a big deal in the thoracolumbar. I know I'm showing a picture of the cervical again, but remember the subaxial spine, the lines you're using are all going to be the same through the thoracolumbar as well. The anterior marginal, the posterior marginal, the spinal laminar, and the posterior spinous line. Okay, so this is a classification, and this is a really what we would consider an old school classification for spine trauma. This is the DENIS classification system. And DENIS used the idea of the spinal lines, those alignment lines that we've been talking about that, and turned them into essentially a strategy for figuring out whether a fracture is stable or unstable. So he came up with a 3-column system. So the anterior column is going to be the anterior 2/3 of the vertebral body, which you're seeing right here. The middle column is going to be just the posterior 1/3. Okay, so it is by far the smallest column. And then the posterior column is going to be all of the posterior elements. So that includes the posterolateral elements, which are the facets, and also includes the spinous processes. All of the spine trauma classification systems after the DENIS classification have all been built on DENIS classification. So you might have heard of the TLIX classification system. That's the thoracolumbar trauma classification system. Again, built on DENIS. You may have heard of the AO spine classification system. All of this is kind of beyond the level you're at right now, but there are things you're going to hear about, especially when you hit intern year or if you're in a surgical service. All of those are built on the foundation of the DENIS classification. So that's why we still like to talk about it. All right, so what is a 1-column fracture? This is a fracture with compression of the anterior 2/3 of the vertebral body. So you can see here this irregular flattening of the anterior 2/3 of this vertebral body as well as the anterior 2/3 of this vertebral body. And while we're looking at it, possibly the anterior of this vertebral body. You can see that the posterior cortex is intact. So this is not involving what's called the middle column. It's only involving the anterior column. Why is this good? Well, if you don't have retropulsion, if you don't have osseous fragments pushing back into the canal, your spinal cord is going to be safe. So the 1-column injury is not usually operated on. It's not a surgical injury because, again, it's not going to be hurting your spinal canal. Your cord is not in danger of being hurt from this one column injury. What about a two column injury? This is called a burst fracture. This is going to involve the entire vertebral body, and you can see the posterior cortex here is retropulsed, and it's sticking, it's putting pressure on the spinal canal. So an injury like this could theoretically hurt your spinal cord. Okay, so these, you're always going to have a consult with a surgical service to make sure that the patient is clinically stable, and if they're clinically unstable, then that is something that they're going to be thinking about operating on. So that's the difference between an anterior column and then an anterior and a middle column. That middle column is what's going to cause all of the pain here along the spinal canal. What about a three column? Well, this is called a chance fracture, otherwise known as a seatbelt fracture. This is a patient that essentially has a large degree of force going through their abdomen, and it shows up as a fracture involving all three columns. So you can see here the anterior column, the posterior column, and then you can see the fracture going through the posterior elements. This is an unstable injury. Not only is it unstable, but there's a high probability that they're going to have abdominal injuries as well. Okay, so this is one to be aware of because this is a potential surgical candidate. And this is just the MRI of it. You can see there are actually hemorrhagic products in the disc, so there's discal injury. Luckily, the cord itself doesn't really have any signal in it, but you can see that all of the fracture, the energy of the fracture went completely through the disc as well as through the soft tissues. And you can see here that the ligaments, particularly the ligamentum flavum as well as the interspinous ligaments, have been completely wiped out and obliterated. So this is just an example of this high rate of speed fracture extending all the way through the disc and soft tissues. All right, so that was the exciting part. That was trauma, but now we're going to talk about degeneration. I think one of the things I want you guys to realize the most with degeneration is what we're actually looking at. I don't know how many of you have actually looked at a radiology report for degenerative spine, but it can be incredibly monotonous. A lot of people think it's very boring. Essentially, what we do is we go level by level, and we talk about each of the findings level by level. And if the radiologist is, you know, a succinct radiologist, at the end they'll tell you what to be worried about. But sometimes, you know, you don't even, when you're reading the impression, know what am I supposed to be getting out of this. So I hope this will be helpful. All right, the first big thing I want you to know is that not all degenerative findings correlate with pain. So I had a good friend that had a small, got rear-ended and had a cervical spine radiograph performed because it was a low impact, not very suspicious presentation. She had a cervical spine radiograph, and she was incredibly focused on the fact that they said that she had early degenerative changes. It just freaked her out. She sent me the report. She wanted to know what is going on with me. And I just want you to know, once you start getting into your early to late 30s, you're already going to start developing a small amount of degenerative change. And that's okay. It's normal. So even though we like to wax eloquent sometimes on degenerative changes of the spine, again, that doesn't always correlate with pain. And that's something that your patients should know. The more information that you give us as radiologists on the actual painful symptoms, then we're going to do a better job of actually localizing the pain generator. So let's say people have mild narrowing of the neural foramina where the nerve is exiting at multiple levels. But you say, Dr. Peckham, they're really having a lot in the C8 distribution. That's where their pain is. And then I'll go down to the C7-T1 level, and I'll see that there is more narrowing at the C7-T1 level, or I'll see something else in that area. Now I know where to focus my search, and now I can tell you, you know, yes, C7-T1 is more narrowed than the other levels. And so it's just more helpful for us. The more pain symptoms you give us, and you don't even have to localize it down to a nerve. You can even say, oh, it's affecting this part of the hand, it's affecting the arm, it's affecting the shoulder. Things like that are going to help us give you a better answer on what might actually be causing the pain, because again, there are a lot of joints, a lot of small openings, and it's hard for us to always know who's having pain. All right. So, cervical degeneration. Oftentimes people will get radiographs for degeneration because it gives you kind of a lay of the land and it lets you see different changes. So for example, on radiographs, you're going to see productive changes. These are called osteophytes. You can see these smooth anterior surfaces of the vertebral body, and all of a sudden it becomes pointy and overgrown, and the AP diameter of the vertebral body increases. These are called productive changes or osteophytes. What causes them to happen? Well, the disc is degenerating. It's degenerating to the point that it gets thinner and thinner and thinner. Maybe it's bulging out the back. We don't know unless we get an MRI. But what happens is now the bone is in closer contact with the other bone, and it's going to start making productive changes just to kind of buffer the constant contact it's having. So it's going to get overgrown. So not only do you get overgrown osteophyte complexes, but you can have overgrown facet joints too. So you can see how narrow this joint is, and you can see all this sclerotic change along the joint itself, and that is just an overgrown facet joint. What about the uncovertebral joint? Well, these little, I guess they look like sails on a ship. These are the uncovertebral joints. Again, these are only in the cervical spine. They do not exist in the thoracolumbar spine. And you see how smooth and beautiful this one is. This is, I think, a 23-year-old patient. It just looks like a lovely joint. This is the joint right here itself. So you see bone here, space here, bone here. So this is the uncovertebral joint. This is a patient with degeneration. You can see that that's now become very spiky. It's gotten more sclerotic, and you can look at the other levels. This uncovertebral joint is very, very narrow. It's narrow here. So this is just an example of productive changes in the uncovertebral joints. So why does all of this matter? Well, I'll just give you a couple things about the cervical spine that tend to be true with most patients. If you have degeneration of the intervertebral, and I call it a quote-unquote joint, it's going to cause most often spinal canal narrowing. And how is that going to present? The patient will present with myelopathic symptoms, not radiculopathic, but myelopathic, because it's affecting the cord itself. So you can see here, you've got a disc bulge, you've got a disc bulge, you've got a disc bulge, and all of these are contributing to spinal canal narrowing. All right, what about degeneration of the uncovertebral and facet joints? These are going to cause different findings. These are usually going to cause radiculopathic findings, so findings of the actual nerve that's exiting. So myelopathic are going to be clinical symptoms of cord. Radiculopathic are going to be clinical symptoms of nerve. So nerve tends to be unilateral, right? Unless both foramina are narrowed. Myelopathic is going to tend to be more bilateral. So these are just different things. When you're doing an exam, you're trying to figure out, what is this patient having issues with? You want to think, is it radiculopathic or is it myelopathic? So I've talked about these quite a bit, but here we have the facet joint. Here we have the uncovertebral joint, which you got to see nice pictures of on that prior radiograph. So what do they do? This is an overgrown uncovertebral joint. This is a T2 sequence. The bones look quite dark on a T2 sequence. Well, on this one, the fat can be bright, but that's a... Anyway, I'm not going to go into MRI land, physics land for you guys, but essentially, overgrown sclerotic bone is going to be dark on T2. So you can see this overgrown sclerotic bone. That's the uncovertebral joint. And then you have this overgrown sclerotic bone. This is the facet joint. Remember, the neural foramen goes between the uncovertebral and the facet. So you have this normal path where the nerve escapes through. But what has happened here? Because of the overgrown uncovertebral joint and the overgrown facet joint, you've got this super, super narrow pathway that the nerve can go through, and it's essentially being crushed, like in this case, an ice cream sandwich. So the nerve itself is being smushed by these overgrown joints. So what does that mean? Let me just go back. The uncovertebral and facet joints are going to tend to cause foraminal narrowing, just like this example. So in the cervical spine, if you have a big disc you're going to think about spinal canal narrowing. And if you have large uncovertebral and facet joints, you're going to think about neural foraminal narrowing. I'm highlighting that because potentially there will be a question about it later. All right, now let's talk about thoracolumbar degeneration. So how do you see it on a radiograph? Remember we talked about the vertebral body is kind of set up differently in the thoracolumbar spine, and the foramina point straight at you on a lateral or sagittal view. So that's what you can see here. You can actually see the foramina pointing straight at you. So on the radiographs, you can see productive changes again like you did on the cervical. You can have these overgrown areas called osteophytes. And then you have these indirect signs that the disc is getting flat and sad and degenerated, and that'll be disc space narrowing. So here you can see that the bone has become very productive around this pretty much non-existent disc, right? This is severely narrowed, and so the bone is trying to protect itself, so it's overgrowing itself. You can also get facet overgrowth on these as well. All right, so what about MRI and lumbar degeneration? So MRI is going to demonstrate the discs looking horrible, and you're going to be able to see how that's going to impact the underlying cord and canal. So here we have this big disc, what looks to be an extrusion actually, but this large disc, as well as overgrowth of the ligamentum flavum, which tends to happen as well. And look at this, it's completely smushed the nerve roots as they're going by. This is sometimes called cauda equina syndrome. So again, cauda equina syndrome is going to be a clinical diagnosis. It's not a radiologic diagnosis. All we can say is those nerves are smushed and it looks dangerous. You as a clinician are going to look for saddle anesthesia. You're going to look for incontinence. You're going to look for all these different signs of cauda equina syndrome. But again, this is going to be a potential emergency. So neurosurgery will have to be called if this patient is having all those symptoms, and a spine surgeon is going to have to go in and clean all of this out. All right, what about facet overgrowth? What happens in the lumbar spine when your facet joints get overgrown? Notice I didn't talk about uncovertebral because again, those only exist in the cervical spine. So facet overgrowth, you're going to get narrowing of the neural foramen. So this is a nice sagittal view showing all of the foramina. You see the bright fat, and then you see this dark nerve coming through it. Bright fat, dark nerve. Bright fat, dark nerve. And then all of a sudden, that bright fat has pretty much become effaced, and you've just got this nerve stuck between the bone. So this is a facet joint that has overgrown, and it's pushing on the nerve, and it's effaced that fat. And that's when you get what's called neural foraminal narrowing. That can cause impingement of the exiting nerve. So this patient is going to say, you know, this looks like the L4 nerve. They're going to say, you know, I've got this weird pain. It's going down the side of my leg, and then it goes all along onto the top of my foot. And you go, oh, that's the L4 dermatome. So when you go and look at your scan, you have an idea of what is causing that. All right. One thing that's a little different about the lumbar spine than the cervical is in the lumbar, really the facets and the disc can contribute to either foraminal narrowing or canal narrowing. So you're just going to have to use your eyes to figure out what is the main problem here. Here you can see the facet joints are overgrown. You see how they're narrowing the spinal canal. Here you can see that there's a disc bulge as well as the ligamentum flavum thickening and overgrown facet, and you've just got this tiny little spinal canal now. So this is the open view, and all of a sudden it's kind of mildly narrowed, and now this is moderate to probably almost severely narrowed, okay? And this is being caused by really everything, the disc and the facets. Okay, so we can't split it up as cleanly as we usually do in the cervical spine. So degeneration of the disc and facet joints can all contribute overall to spinal canal narrowing as well as neural foraminal narrowing. So why do I say neural foraminal? Look, this is a disc. This is not the facet, this is the disc. Here you have an open neural foramen on this side, and now you see the foramen here is severely narrowed, and it's severely narrowed because you have this asymmetric disc bulge. So even the disc itself is contributing to foraminal narrowing in the lumbar spine. So now that you know what all of these structures are, you kind of have an idea of what it is we're looking at. You know, when we say, hey, there's a disc smushing the nerve in the lumbar spine, you kind of have an idea of where we're looking for that. And again, if we talk about facet overgrowth, you kind of have an idea of why the facet overgrowing would smush the nerve as it's exiting. Okay, question number 4. Overgrowth of the uncovertebral joint primarily contributes to narrowing of which region? Is it the spinal canal? Is it the atlantoaxial joint? Is it the neural foramen? Or is it the dorsal epidural space? All right. And then to answer Michael's question, yes, we do end up getting an MRI on a lot of these cases. And the reason we get an MRI is because we, by the CT, have seen that there is a fracture that is serious and that is impinging on the spinal canal. So in those cases, we definitely know we need to go to MRI because we need to know if the cord is injured. But if anybody just walks in off the street or even comes in on a gurney, and you have no idea what kind of fractures they have, what kind of injuries they have, you would be really wasting a lot of resources to order a CT and MRI on them immediately. Because what's going to happen is you're going to have a lot of patients that really don't have any injury, because these are commonly used as screening studies. You're going to have a lot of patients that don't have any injury at all getting both studies for no reason. So the only reason we're going to move on to MRI is once we've seen on CT in a trauma setting, once we've seen on CT that there is traumatic injury, we'd move to MRI. There are some traumatic injuries that don't need an MRI. So I didn't show you all the little small things. If you have a spinous process fracture or a transverse process fracture or something like that, that does not need an MRI. It's only when you start seeing, hey, this is impinging on the canal, it's potentially smushing the cord, there may be an epidural hematoma, that's when you're going to get an MRI. So again, trauma, you're always going to start off with a CT, acute trauma, and then go to the MRI if you need more information. For degeneration, it's a different set of rules, but usually an MRI is going to be most helpful in degeneration after you have made sure clinically that they match all of the criteria to get an MRI. Okay, so we are going to end here with infection and malignancy. God, we've gone through a lot of spine, you guys. It's a lot of spine. Okay, so both CT and MRI can be helpful for infection. So I don't want to tell you only use one or only use the other. They can be helpful for each other. If you are seriously considering that this person has an infection, again, the soft tissues are really helpful for infection. So an MRI would probably be a better place to start. But don't be surprised if the radiologist says, hey, some of these findings, I can't tell if it's degeneration or infection, please get a CT. And the reason that they're asking you to get a CT is you can see different erosive changes of the adjacent bones on CT. So don't be surprised. Sometimes we like to use these studies to help us figure out what's going on, and we'll recommend, hey, I want to see the bones better, or hey, I want to see the soft tissues better. All right. But usually for infection and malignancy, MRI is a really good study. So this is kind of the take-home point I'd like you to have specifically for infection. And I say take-home point because I will probably be asking you a question about it later. Infection likes to center around joints. It doesn't like to live in the middle of a bone. It likes to live in the joints. And that should make sense to you. If you have an infection in your hip, you think about septic arthritis of your hip. Infection of your shoulder, you think about septic arthritis of the shoulder, septic arthritis of the elbow, septic arthritis, all of these are joints. This is where infection likes to go. There's a whole pathophysiology behind why infection likes to go to the joints, but it is no different in the spine. This seems like something that's not a crazy idea, but there are a lot of people that will read a discitis osteomyelitis study and say cannot exclude malignancy. I just want you to know that if something is centered only around the joint, the chances of it being infection are much higher than the chances of it being cancer. So these are things that I use when I'm reading a study. Sometimes cancer and infection can have a lot of similarities, and they're difficult to figure out between the two. But just the fact that it's centered around a joint is one of the things that helps me figure out when something is infection over malignancy. So this is just an example. You have one vertebral body here, another vertebral body here, and you've got this huge intradiscal abscess. And then you've got all of these reactive changes around that intradiscal abscess. This is a post-contrast study. You can see the abscess itself is not enhancing because it's fluid, but all the rind around it is enhancing. And then you see enhancement in the bones next to it. This is called discitis. And then all the inflammatory changes in the bone around it due to the infection is called osteomyelitis. So this is an example of discitis, osteomyelitis. You also have some enhancement in the epidural space along the spinal canal. That could be early infection, so something we would call a phlegmon. It's not specifically an abscess yet because it's not fluid, but it is all this infected, inflamed tissue. So this is just a nice example of discitis, osteomyelitis. All right, let's see. Okay, what are the other joints that we've been talking about? We also talked about facet joints, and here you've got all of this enhancement around the facet joints. This is called facet septic arthritis. And again, you're thinking infection. If you see all of these inflammatory changes around the facet, now the facet can be more difficult, right? And the disc can be as well. Because if you're seeing just inflammatory changes, just degeneration can give you inflammation, right? So you don't always know if it's infection. But if you start seeing soft tissue abscesses, epidural abscess, things in the soft tissues that look like infection, then you're going to say, well, this is all probably infection. So this is an example of a patient that did have facet septic arthritis. So again, if it's around a joint, you want to think about infection. Degeneration can sometimes give you all these inflammatory changes, but especially if you start seeing abscesses in the epidural space or in the soft tissues, you're going to go, hey, this is probably an infection. This can again extend into the epidural space. You see these little pockets of fluid with all of this enhancement around them. This is called an epidural abscess. So these can be dangerous because they can put pressure on the spinal canal, and oftentimes the surgeon may have to go in, pop the lid off of this, and wash it out. And then if the infection itself gets into the spinal canal, so it gets through the dura into the canal itself, it can actually start coating those cauda equina nerve fibers that we talked about. So here's the tip of the spinal cord called the conus medullaris, and then we have all of these horsetail fibers coming off, and you can see all of this enhancement. It's pretty much just like dependently layered at the bottom of the spinal canal. This is a patient with coccidiomycosis, so it's an atypical infection, but we can definitely get this picture if the infection gets into the subarachnoid space and is able to layer into the spinal canal. All right, so that will take us to malignancy, and we'll end up here. So malignancy, different than infection, likes to affect the vertebral body. So these are not going to be as centered around the joint. You could say, Dr. Peckham, this is right up against the joint, but as you see, there's nothing on the other side, okay? So these lesions are not centered around the joint. Even if they touch the surface of a joint, you're usually not going to see, you know, another on the other. I mean, theoretically, there could be another on the other side, but it's not going to be centered on the joint like infection. Here you have, T1. Again, we talked about how the fat is bright on T1, so all these dark things in it are going to be cancer. And then this is a sequence we use called STIR. The STIR sequence nulls all the fat and makes all of the other things show up even better, especially inflammation. In this case, all of these bright things are little small tumors, so malignancy throughout the bones. And then this is a post-contrast sequence, and all of these little metastatic lesions are enhancing on the post-contrast sequence. So as you can see in malignancy, they're often centered in the bone, central to the bone, but they're not centered around a joint like you would see in infection. All right, so again, T1, usually bright fat. Malignancy is going to look dark. On STIR, the fat is saturated, so it looks dark, so malignancy oftentimes is going to look bright. And then on a post-contrast T1, the malignancy is going to enhance. Similar to infection, malignancy can extend into the epidural space, in this case around the nerves. So this, remember, is the neural foramen. You have nerves going through the neural foramen. Now you've got all of this soft tissue metastatic lesion. It's smushing the canal on this side and it's going along the nerve on this side. And here you've got all of this enhancement along this metastatic lesion. And it can also coat the spinal cord and nerve roots, similar to what we saw on the infection study, right? So here's all this enhancement going along the spinal canal, along the cord. All right, question number 5. Which location of signal change is going to be more concerning for infection? A, centered around the epidural venous plexus, B, centered within the vertebral body, or C, centered around the intervertebral disc. So which is going to be more concerning? All right. Okay, so that was our last question. In summary, knowledge of strengths and weaknesses of imaging modalities is incredibly important for knowing what study to order. Again, if you're concerned about an acute fracture, you want to start with the CT. It is the most sensitive for finding acute fractures. If you're more concerned about soft tissues, the discs, the spinal cord, the nerves, things like that, then you're going to be thinking MRI. And if you're wanting to look at mobility, especially if a patient is weight-bearing, you want to use a radiograph. Second point is alignment of the spine is very important for trauma and degeneration workups. You want to look for traumatic listhesis, where the facets are offset from each other. You want to look at alignment of the vertebral bodies. Is the vertebral body crushed? Is it a 1-column injury, a 2-column injury, 3-column injury? These are all the things you want to do when you look at alignment. And then finally, a basic understanding of what a radiologist looks for is important for getting the most out of a report. So when you see these terms floating around like facet and uncovertebral hypertrophy or discogenic end plate changes, all these different things, you have an idea now of what it is that our eyes are looking for. Oh, okay, so infection, what exactly did you mean by layer into the spinal canal? So I know you probably had Dr. Osborne's lecture yesterday or this week, and she probably talked to you about all of the different compartments in the brain. The subarachnoid space, then you have the dura that overlies that, then you have the subdural space, which is a potential space, and then you have the epidural space, which is outside of that. Well, the spine works the same way. The spinal canal is subarachnoid. It's within dural layers. Outside of the dural layers, then you have the epidural space. So when I say layering into the spinal canal, it means the infection itself has actually made it through. It either started within the subarachnoid space or made it through the dura into the subarachnoid space to the point where it's now actually along the spinal cord itself. So it is in a different compartment of the spine than outside of the spine, okay, or outside of the canal. It's now inside of the canal, and that's how it's able to layer along the spinal cord. So yeah, the same compartments in the brain are also in the spine, and that's why it's really important for us to be able to say what compartment the infection is in. So for example, let's say somebody has discitis osteomyelitis, and you say, Dr. Peckham, we really need you to do a lumbar puncture. Well, if I do a lumbar puncture, my needle will go through the epidural space where the infection is and now communicate into the spinal canal itself. So would a lumbar puncture be helpful, or could it be potentially spreading infection into the spinal canal itself? And I would say you'd really have to be careful, right? Because if you did a lumbar puncture, you could spread the infection into the canal itself because you're now puncturing the dura and allowing the infection to extend. So just knowing about all of these different spaces in the spine is really important as well. It's a bit beyond the scope of this lecture, but that's just letting you know, hey, same layers in the brain, same layers in the spine. Anybody have any other questions? All right, well, I hope that was helpful and that you have a little bit of a better idea now of what we're looking for in the spine. And best of luck during this trying time. I hope you guys are doing well and everybody's staying safe and healthy. And I'll catch you guys later. Have a good one. All right, bye.